let's do it. Let's review a subject. It's really hard to convey all the limitations and challenges of doing point of care ultrasound in critical care nephrology. However, I think I will take this few minutes that we have and share with you one of the key and fundamental issues that I've seen with people using ultrasound making clinical decisions, sometimes taking or making the wrong turns and making completely not accurate decisions based on a lack of full knowledge of whether of the images they're obtaining, but also of the physiology and interpretation of these images as it relates to the patient's pathophysiology. And so, first of all, I have no conflict of interest. And let's talk about, if you talk about limitations of point of care ultrasound, well, there's technical limitations, of course, and there's a mountain of those. And they can be summarized as, I've chosen this specifically because these are, in my opinion, one of the most important technical limitations that will result in erroneous diagnosis and erroneous treatment of patients. And that, in the base of the pyramid would be lack of supervised training, and that's very frequent in my country. Relying on a single parameter for making decisions, interpretation of noise, a signal. Remember, as clinicians, we're exposed to a lot of noise, and that means that sometimes you need to maybe not interpret every single finding you have if it doesn't fit the overall clinical picture. And that has to go hand in hand with overconfidence, right? So once we get some skills with ultrasound, you'll see people that are really confident in the decisions they're making, and they don't actually ask for second opinions. They don't question whether they're getting the right information. And that, to me, is one of the most important causes of misdiagnosis or misdirection. And then the lack of proper documentation. You'll see this from time to time. People using ultrasound to make decisions, and then after another clinician come or you hand in the shift, you say, why were you doing this treatment? And then they'll say, because somebody did ultrasound. Okay, so what were the findings? They're not documented anywhere. The images were not saved. There's no single progress note that relates to these findings. And so, that could cause us problems because there's no documentation of what the specific findings were that led to this treatment action. And then, of course, in the top of the pyramid, and there's nothing we can do about it, is poor acoustic window. And that's, the most terrible technical limitation that we can have as sonographers. We can get around that. For acoustic window, you can get around that if you, for example, you really need to do hemodynamic monitoring. Well, you could go for transesophageal echocardiogram for hemodynamic monitoring, or we could just go back to basics and use the gold standard for hemodynamic monitoring, which, if you really know how to use, gives you a lot of information, which is the pulmonary artery catheter. But I will say that even with a pulmonary artery catheter, there's still a significant limitation for using as a hemodynamic monitor if you don't know what you're doing, if you don't know the pathophysiology and the physiology behind the circulatory system. And so I will focus on this in the later point in my lecture. For now, I will try to highlight one of the some examples of these technical limitations. For example, interpretation of noise as signal. I just had a recent case, very recent case, where a patient with cirrhosis presented to the emergency department. The patient had some GI bleeding, came with acute kidney injury, and the nephrologist performed ultrasound. And this is what Gregorio was talking about. He was talking about using ultrasound in the small vessels of the kidney to try to look for renal congestion. And you see, the more discontinuous the flow in the intrarenal veins, the more congestion the patient is presenting. And then, of course, if you have a patient with cirrhosis and renal congestion and acute kidney injury, maybe the correct treatment is not to load him up with albumin and fluid and maybe to give diuretics or early vasopressors, right? And so the nephrologists who performed this exam thought this was a biphasic waveform. You can see the arterial waveform on the top. You can see the venous waveform in the bottom, where you can see some signal that looks to be discontinuous and could be biphasic. You see one and two phases, one and two phases. However, you know, this is probably the effect of poor acquisition, poor technical skills. So I said, let's go and repeat this exam by finding a proper interlobar vessel. You know, you have to be on top of the vessel. Here, I cannot even see the vessel. I repeat the exam. Here I am on top of an interlobar vessel. And now you can see this is the same patient at the same time, maybe 2 minutes difference between the first examination and the second examination. And now we can have a clear signal of a continuous flow. You might have been tricked and you say, oh, this is a biphasic because there is an interruption here, an interruption here. Well, remember, if your Doppler signal is not of a high quality signal, you might get a lot of noise. And if you interpret this noise as interruptions, as a signal, you might make erroneous decisions. You know, this is why we do the complete Vexus examination in patients with heart failure, because maybe you can get an erroneous signal in the kidneys, but the portal vein will be normal, the inferior vena cava will be normal. And in cirrhosis, where you cannot use the portal vein and you cannot use the hepatic vein, we will use the jugular vein, we will use the intrarenal vein, and now we're adding the femoral vein Doppler. So in order to have more information and avoid this kind of mistakes. Now, what about relying on a single parameter? This is, I've seen this happen many times. Of course, everybody knows you should not rely on a single parameter, but sometimes this parameter is so strong and so embedded in the clinician's mind that they get anchored to this parameter and it guides the whole treatment approach to this patient. This is a case I saw a year ago. It was a terrible case, a patient presenting with shock. And the intensivist that performed the point ultrasound, and I was actually there seeing how the clinician performed the ultrasound, and I saw his interpretation. I tried to dissuade him from this interpretation, but my efforts were futile. The intensivist thought that this shock, this patient in shock, was because of a cardiogenic shock, because he measured something called the EPSS, which is the E-point septal separation. And that is the distance between the anterior leaflet of the mitral valve and the interventricular septum. When this distance is increased, we can say that this is a sign of low ejection fraction or poor systolic function. And so the cause of shock, this is a patient with shock and has a very high EPSS, I'm sorry, it should be high EPSS. Then it could be that this is a pump issue and this is a cardiogenic shock. And so the intensivist, because he measured the EPSS, he thought this was cardiogenic shock. And the treatment for this patient was decided to be an inotrope, dobutamine. So the clinician ordered the dobutamine infusion. And this is where I said, no, you cannot give dobutamine to this patient. Because this EPSS that you're measuring should be high EPSS, not low EPSS. This high EPSS that you're measuring is more related to a valvular issue. You can clearly see a calcified, hyperechoic mitral valve that is barely opening. And actually, the contractility doesn't look that bad. No? The endocardial excursion is good. The myocardial thickening is good. But the cause of shock could be severe mitral stenosis. There's not enough time for the ventricle to fill up with blood because blood has to come through a very small orifice, right? And so I said, if you add dobutamine and you create further tachycardia, because dobutamine is cause tachycardia, this patient is going to crash. Well, they did not listen to me because they were already anchored in their diagnosis of cardiogenic shock. They gave dobutamine, and this is not an exaggeration. It was probably 20 seconds after the infusion of dobutamine reached the patient's peripheral vein, the patient went into ventricular fibrillation. Why? Because dobutamine increases tachycardia. There is no enough time for ventricular filling. and this causes catastrophic low cardiac output, and the patient goes into ventricular tachycardia and cardiac arrest. So, relying on a single parameter, what if this parameter had been ignored and all parameters were taken into account? Good myocardial exclusion, good myocardial thickening, right? They would have looked at the actual anatomy of the valve. What if they had done Doppler, transmitral Doppler, to look at a gradient of mitral stenosis? This patient would probably not have gone into cardiac arrest. But this is a problem. The EPSS was anchored in the clinician's mind, and then catastrophe followed. Next, what if you are very good at ultrasound and you have very good 2D windows and very good acquisition, but you have poor Doppler skills? And Doppler skills sometimes means interpretation of Doppler artifacts, right? Such as aliasing and Doppler settings. For example, you might be very good at ultrasound and 2D windows, but you do not know how to set the proper scale, the proper baseline, the proper sweep speed, and to interpret the good Doppler signal, which has to have a clear envelope, which is the modal velocity, also called the spectrum, and a clear spectral window for you to be able to interpret this Doppler signal in some scenarios. So, for example, you see this patient, this is the real case of a patient with a shock that had an LVOT VTI of 36 as measured by the intensity. And they say, oh, this is distributive shock, clearly. And so we need to keep doing norepinephrine and giving antibiotics. What do you think of this Doppler signal? This is a terrible Doppler signal, right? This has no spectrum, no spectral window. It has aliasing all over. You cannot even see the end of the signal. That means it's a very fast velocity flow, very turbulent flow. This cannot be measured. This cannot give you the information that you're looking for to calculate or estimate the cardiac index or the cardiac output or the stroke volume. So for you to be able to interpret a VTI, you need to have laminar flow. For example, as a flow that here Dustin from a YouTube channel is creating with a hose in a pool, and he's creating laminar flow. What does laminar flow mean? Laminar flow means that the flow is organized and all the red blood cells are flowing at the same speed. Or here, all the water molecules are flowing at the same speed. And when water molecules are flowing at the same speed, their refractive index is different. And so light passes through it more clearly, does not distort. The flow of water seems very clear. And this is the same for Doppler. If the speed of blood of all the red blood cells is the same during the ejection volume, then all red blood cells will be organized in a white thin line. And this is the thinnest spectrum. You can see the thinnest spectrum. And then whatever there's no velocities of red blood cells would be a spectral window, which is this dark window right here. This will tell you this is laminar flow, this is organized flow, it's not accelerating. And if you do not have these characteristics with a very thin spectrum, a clear spectral window, and a closing click, you should not measure the VTI. But also, if you're looking at this very high velocity, right, and the broadened spectrum without a spectral window, then you're in trouble because this is turbulent flow and very fast flow. You cannot measure VTI in this situation. This is similar to this kind of flow where water is disorganized and you cannot see a very clear passage of light through the water molecules. This is turbulent flow. So be careful. If you have turbulent flow, this means probably there's some type of obstruction or stenosis. If this is obstruction, then this changes your treatment plan completely. Your VTI is probably not 36, probably very low. And you have obstruction and you have an obstructive shock, which is likely being caused by obstruction of the outflow tract. This is common in sepsis. and you will have a dynamic obstruction of the left ventricular outflow tract, leading to low cardiac output and an obstructive shock. And this happens when, for example, the mitral valve is compressing or obstructing the outflow tract, the passage of blood from the left ventricle to the aorta is being blocked by the mitral valve, or the interventricular septum, if it has a sigmoid shape, in the setting of a very low cardiac filling. So for example, a very empty left ventricle will get the mitral valve very close to the outflow tract, and it will cause obstruction. And as you can see, when there is narrowing, obstruction, or stenosis, your flow has a spectral broadening. That means your spectrum becomes thick. And then it becomes very thick without a spectral window and a very high velocity. And, of course, dynamic left ventricular outflow tract obstruction will present with a very thick spectrum, but also a very fast and dagger-shaped spectrum that has a very high velocity, okay? And so this is very relevant to recognize, not to measure the VTI and say, oh, VTI is 30, 33, 34, but really the shape, the spectrum, and the maximum velocity to recognize that this was, in fact, an obstructive shock. Well, another problem with Doppler, and this is the deeper problem. So all this mountain of problems amounts to, in my opinion, a very small part of the technical limitations with ultrasound. This is not as relevant as the deeper problem. The deeper problem is this one. People who are doing ultrasound are reading ultrasound textbooks. So here is Neil Sonny's point of care ultrasound book. And this is other very common knowledge or emergency ultrasound book, textbook of clinical echocardiography. And they're experts at reading these books, but they forget to read the most fundamental books in medicine, which is medical physiology. I recommend, if you are starting your journey of doing point of care ultrasound and trying to think of hemodynamic monitoring, you need to know physiology. And this is very clearly detailed on a medical book called the Guyton and Hall Medical Physiology. This is just a book that you read as a medical student. And in many places I've seen, this knowledge is forgotten or is never understood by clinicians, and they go straight and read the ultrasound books without a deep understanding of physiology. And this leads to all kinds of issues with interpretation. Even if they're good sonographers and they have no technical problems, they will still interpret things in the wrong way. For example, this is a very common scenario that people say, I'm doing point of care ultrasound to assess for volume status. No. Point of care ultrasound cannot assess volume status. Really, what's volume status? This is a term that's very nebulous. Okay? That's not the correct question. What we are doing, you're trying to assess whether cardiac function curve is actually displaced to the right, displaced to the left, and the point of equilibrium, if you are in the ascending part of the Starling curve, or you're already on the flat part of the Starling curve. But this has nothing to do with volume. A patient can be in the ascending part of the Starling curve, for example here, and still be very volume responsive because has a normal cardiac function, no diastolic dysfunction, no systolic dysfunction, very good heart, but could still be very severely fluid overloaded. Think of a young patient with pancreatitis and a normal heart that's 30 liters fluid positive in a fluid balance. The patient will have edema, the patient will have pleural effusion, might have abdominal compartment syndrome because of all the ascites, because of all the fluid that's being given to the patient. And then you will do POCUS and you will do passive leg right, and you will see, oh, this patient is fluid responsive. The patient, the vena cava is small, the cardiac filling pressures are low, the rexus is 0. The patient must still have hypovolemia. Impossible to have hypovolemia when you have 30 liters fluid balance positive and the patient has anasarca, severe peripheral edema, And so this is very important to distinguish. We are not assessing volume status. We are doing hemodynamic assessment. And point of care ultrasound is really useful when we have heart failure. But when we don't have heart failure, then what you will see in ultrasound cannot distinguish from a normal patient compared to a hypovolemic patient. This is a very important key point. So the question of, is my patient hypovolemic? This is not a good question. What kind of question is that? Your ultrasound cannot tell you if your patient is hypovolemic. The correct question will be, what hemodynamic intervention is more likely to improve perfusion without causing harm? That is the right question. And that needs a brain, that needs physiology, and that needs technical knowledge of ultrasound. Let's go with a case, and this is the last thing I'm going to show of how to use correctly ultrasound. For example, this is a case of a patient with shock and oliguria. And you see the patient has a left ventricle that looks very empty, very hyperdynamic. There's almost no blood inside of the left ventricle. The lung ultrasound is clear without V lines. And this is, you have to believe me because it was a difficult window, but you have to believe me, this is a very small, hair, thin vena cava, very thin inferior vena cava. And so this might be interpreted as hypovolemia, really, because the patient is in shock, oliguria, hypoperfusion. The skin was actually mottled and blue and hypoperfused. But if you say, oh, ultrasound shows sign of hypovolemia, you have made a mistake. You don't understand physiology. The correct assessment is ultrasound shows that there is likely no elevation in cardiac filling pressure. That's it. The patient does not have heart failure. But this does not necessarily mean hypovolemia. The patient might be hypervolemic or euvolemic and just have a severe septic problem. For example, from venodilation leading to low preload and arteriolar dilation leading to low afterload. This will look exactly the same, even if the patient is euvolemic or even hypervolemic. So this has nothing to do with volume. This has just ruled out increase in cardiac filling pressure. So this is likely not obstructive shock from tamponade, for example, because the right ventricle is good. This is not pulmonary embolism because the vena cava is not dilated. And this is not cardiogenic shock because the heart has good contractility. But you cannot say this is hypovolemic shock just looking at this images. This could very well be very severe sepsis, right? And so this was the patient. This was a patient with diverticulitis, severe sepsis. Look at the skin, very poor perfusion, very tachycardic. You know, the pulse oximetry didn't even capture the oxygenation because of poor finger perfusion. And look at the dose of norepinephrine. This is a very high dose, 40 milliliters per hour of a normal dilution of norepinephrine. So this was a really sick patient. Okay, with these images, very empty left ventricle, small vena cava, clear lungs, you know. And so what everybody would do receiving this patient in the emergency department, especially because the patient was diagnosed with severe diabetic ketoacidosis and diverticulitis, of course, the first approach would be, well, what if the patient might be hypovolemic? Let's try to give some fluid. This is reasonable, but you should not call this patient hypovolemic. You'd say, okay, he could be hypovolemic, and he tolerates fluid. What do I mean by tolerates fluid? There's no pulmonary edema, there is no congestion, there's no peripheral edema, probably little harm of trying fluid, but do not believe that you are doing the correct thing. You have to reassess. So we give fluid, see what happens. Oh, the patient did not improve. 2 hours later, after a lot of fluid was given, this patient received 3 liters of crystalloids. The patient is exactly the same, with a very hyperdynamic circulation, with a lot of norepinephrine, with very poor skin perfusion. And so our question for ultrasound would be, will additional fluid bolus improve perfusion? We cannot say the patient is hypovolemic because these findings, a hyperdynamic circulation, could be true hypovolemia, that's right, but could also be sepsis from venous pooling and low afterload. And both conditions are fluid responsive states, but only true hypovolemia would really improve with more fluid, and sepsis will likely cause harm if we keep giving fluid and keep giving fluid. So let's keep that in mind. Is it a good strategy to keep giving fluid to these patients who already received a lot of fluid and did not respond? Well, let's see. This is what led us to write this editorial or this educational paper, where we try to change the approach. Let's not care too much about if the patient is fluid responsive, but we now care whether the patient is fluid tolerant. And what does that mean? If we think the patient might be hypovolemic, then we rule out that some signs of fluid intolerance, congestion, lung pulmonary edema, and intra-abdominal pressure elevation. And after we rule this out, then we could perform a fluid responsiveness test. And if the patient is fluid responsive, then there might be some benefit of giving fluid. But let's consider if the patient has severe sepsis, that there may be glycocalic damage, and there will be third spacing of this fluid. And so the benefit of giving fluid might be short-lived. So anytime we are giving additional fluid, we need to reassess for tolerance. So what happened in this case? After we gave 3 liters of fluid and the patient is still hypoperfused, we reassessed the lungs for fluid tolerance. And remember how they were very clear. Now we have a lot of B lines, no longer tolerant, but the patient is still in very severe shock. And this is when we decided to look at the VTI. The VTI was very turbulent. We see a very increase in the velocity of, look at this, the velocity greater than 2 meters per second is very elevated, and greater than 4 meters per second is likely to be very hemodynamically significant. So 6 meters per second is a staggering velocity, which means a very severe obstruction of the LVOT. And how do we cure obstruction of the LVOT? Well, we need to understand why this is happening. Obstruction of the left ventricular outflow tract is usually caused by a displaced mitral valve. The anterior mitral valve is compressing the outflow tract, and instead of being all this diameter of the outflow tract, it's only this small diameter, right? And why does this happen? Because the ventricle has very low volume. And so we need to increase volume. How do we increase the volume of the left ventricle? We need to lower the heart rate, so give it more time to fill up. We need to increase afterload, and we might be able to increase preload. So fluids only increase preload. We have tried fluids in this patient, and after a couple of hours, fluids went out of the intravascular space, and it didn't work. So we need to do another strategy. And another strategy in sepsis, very well described, is to increase afterload, but without increasing tachycardia. How do we do that? Well, norepinephrine is terrible. Norepinephrine actually worsens this problem because norepinephrine, although it does increase afterload, it will increase the heart rate, and it will also increase inotropism. So in this situation, norepinephrine can lead to sudden death. And the answer, this has been published, the answer in shock, in septic shock, in outflow tract obstruction is to change your vasopressor strategy. Norepinephrine will cause tachycardia and will empty the ventricle. But vasopressin will not cause tachycardia, will increase afterload, and will not increase inotropism. This is a case series of patients with sepsis and dynamic ventricular outflow tract obstruction. And you can see treatment with vasopressin reduces the gradient and improves perfusion. So this is what we did. Look at the patient, how the gradient was doing with a very high dose of norepinephrine. We switched off norepinephrine. We did not give any additional fluid. We just changed to vasopressin. And look at the gradient now. It was 5.9 meters per second, and after vasopressin, now the gradient is 1.1 meters per second. So changing from a tachycardia-inducing vasopressor to a non-tachycardia-inducing vasopressor without inotropic properties changed the whole physiology of the left ventricle, and it de-obstructed the outflow tract. And now look, after vasopressin, you can actually see now the skin, the perfusion is doing much better. And look at even the finger is now transducing the pulse oximeter signal because we have improved perfusion significantly by changing from norepinephrine to vasopressin. This is a really very clear example of how not to use ultrasound to think this is hypovolemia, when really there was a deeper problem needing understanding of physiology. And of course, As I'm a nephrologist, I was consulted because the patient was in oliguria, and after all of this, the patient produced a lot of urine, and my job was done. And so, for final slide, I say there's a certain beauty of having a library of unread books. This is Umberto Eco's anti-library. This is how it's called. An anti-library is a library of unread books. It's always good to have a library of unread books because you will always discover something new when you're bored. But this library cannot contain the physiology textbook. Your physiology textbook has to be on the read category. Never put it on the will read, will never read, how read, or intended to read. No, no, no. Medical physiology has to be on the read category and completely memorized and completely understood before you are an expert on imaging and ultrasound. And with this, I will finish the lecture. Thank you for your attention. And again, it was an honor to participate in this meeting.